Hello, pharmacology friends. We are going to discuss adrenocorticoids today. So, those are going to be steroid hormones that originate from the adrenal cortex, and we can also give medications that mimic them or block them. So, we'll talk about their use and applications. When you're thinking about how to approach this topic, most importantly, I would say it is understanding the normal physiology of what the adrenal glands do. So, what are the products that they make, including the glucocorticoid and mineralocorticoid products, your cortisol and your aldosterone. And then, if you think about the pathology, what are some diseases where you would have hyper or hyposecretion of some of these adrenal hormones? If you can locate their site of action, that helps you understand how they work. And then you'll want to distinguish between the medications by why they might be used, so their indications and their route of administration, and whether or not something is used for local treatment, meaning something just in an area where a lesion is, or for systemic treatment, where we're targeting the entire body. So we refer to these compounds specifically by adrenal corticosteroids. And that word cortico lets you know that they are a product of the cortex of the adrenal, not the medulla. And the word steroids is referring to their structure. So a steroid hormone has the same backbone associated with it. And our native substance that is the precursor to cortisol is our cortisone. We have aldosterone, and then we have the synthetic version of our cortisone, which is hydrocortisone. And to make life a little bit simpler, when we refer to medications that are cortisone related, we're going to call them hydrocortisone, so you know that it's a drug. So they all have the same backbone, and they are all manufactured out of cholesterol through this cholesterol manufacturing pathway I'll mention later down the line. When we put these into categories, we have glucocorticoids, and that word gluco came about when this substance was first determined to have a huge impact on carbohydrate metabolism, which would give us availability of glucose. So our primary glucocorticoid is cortisol, and the gluco, again, comes from its role with carb metabolism. And it's also really important with immunosuppression. It is what we call the stress hormone, and it is what makes you able to live in times of really severe stress. It allows energy to be available for expenditure, and it also routes energy away from things that might take up any blood flow or really any energy from the body that we would need in the time of an acute stressor. Mineralocorticoid, that word comes from mineral, referring to its importance with electrolyte capabilities. So our electrolytes are ions, things like sodium, potassium, calcium. Mineralocorticoids, they are most important for that. And then we have a final layer of the adrenal cortex, which makes androgen, specifically DHEA and the isomer DHEAS, which has minor pubertal effects. It has a lot to do with hair growth in the axillary and pubic regions, and then also later on the mediation of libido. So these are the native substances, and we are going to either be giving things that mimic them or that block their manufacturing in the body. So why I mentioned that understanding the physiology is such an important part of this chapter in particular is that the drugs act exactly how the native hormones act. So they're really just an extension of the physiologic effects, which are going to include the desired effects, like maybe anti-inflammation, and then the undesired effects, like tissue thinning and muscle wasting. Remember our two native substances, we've got cortisol, we've got aldosterone, and just a little note that when we administer cortisone, because of this enzyme that exists, cortisone is reversibly converted into cortisol. So whenever we give a cortisone type substance, we'll make it into cortisol. Another important note is with regards to their location of activity. We have within nearly every cell in the body a glucocorticoid receptor, a GR, and those glucocorticoid receptors can bind cortisol. The other type of receptor that's important is a mineralocorticoid receptor. So things like aldosterone bind primarily to mineralocorticoid receptors. Another important thing to keep in mind is that cortisol substances, so glucocorticoids, can also bind to mineralocorticoid receptors, which means that cortisol in and of itself has both glucocorticoid and mineralocorticoid effects, where aldosterone does not have glucocorticoid effects. When you give medications, some of them are going to have both glucocorticoid and mineralocorticoid activity. So if we keep in mind that we always want to keep low the amount of medication that somebody is on, we can maximize the benefit by choosing the right med by its mechanism of action. So here's a little look at what the mechanism of action is. We have our corticosteroid substance binding to its receptor subtypes. So we'll keep an eye here. Most glucocorticoid receptors and mineralocorticoid receptors are within the cell, in the cytoplasm. We do have some membrane-located glucocorticoid receptors as well, but what the main point here is that, again, corticosteroids, depending upon which type they are, the more closely they relate to cortisol itself, they can bind to both glucocorticoid and mineralocorticoid receptors. Once that binding interaction occurs, that complex of the drug plus the receptor gets translocated into the nucleus so that it can interact with the DNA and we get new proteins through transcription and translation. These receptors, they exist in nearly every cell in the body. That means, for the good part, that we can give medications really in any way we want. We can put them directly on an area, we can give them systemically, and really all tissues will have an effect. For the negative impact there, that means there's going to be widespread side effects because we're not specifically targeting something. We're going to be giving a medication that interacts with the entire system. So again, these two receptor subtypes, mineralocorticoid and glucocorticoid, exist. Glucocorticoids themselves can bind to both, and mineralocorticoids can only really interact with mineralocorticoid receptors. They don't bind well with glucocorticoid. So keep in mind most things that end in zone, so your cortisones, your hydrocortisones, will have both glucocorticoid and mineralocorticoid effects. Here is a drug table, and you see these all the time in these steroid chapters. What you're looking at here is a table showing you relative potencies and equivalent doses of corticosteroids. These are going to be organized first by compound, so what the medication is, its ability to bind to a glucocorticoid receptor, well, that was a messy line, and then its ability to add or bind to a mineralocorticoid receptor. So the main reason we would give something that's glucocorticoid is for its anti-inflammatory properties, whereas a mineralocorticoid, we would want to look at its ability to retain sodium, which is what aldosterone naturally does. Next in the table, you have how long these substances last in the body, so their duration of action, and then the equivalent dose that could be used to get the effect that you want without suppressing the physiologic HPA axis, the hypothalamic pituitary axis. So just to orient you to this, first off, we've got hydrocortisone, and I want you to notice that if we look at its glucocorticoid to mineralocorticoid activity, it is a 1-to-1 equal amount. So hydrocortisone, you're going to get the full spectrum of that activity, meaning if you need to substitute or replace a hormone for somebody, why not choose a substance that is going to give both mineralocorticoid and glucocorticoid activity? You'll see that cortisone is also this way, where it is a matched glucocorticoid to mineralocorticoid type of substance. Both of those substances are also referred to as short-acting drugs, where generally they're going to last about 8 to 12 hours in the body. Really, the one that's very different that you should memorize, that's a little bit off than the rest, is Fludrocortisone. So if you remember, it starts with F, that might help. Fludrocortisone is the only one on here with a higher binding affinity to mineralocorticoid receptors than glucocorticoid receptors, meaning if you want to choose something that specifically targets aldosterone type activity in cases of we'll talk about that, even Addison's disease, we can give fludrocortisone. And this now enters into the intermediate drug class, and those drugs last about 12 to 36 hours in the body. The remaining drugs on the list, your prednisone, prednisolone, methylprednisolone, those are all going to be greater glucocorticoid inactivity with minimal mineralocorticoid effects. And then your last three drugs, triamcinolone, betamethasone, and dexamethasone, have zero mineralocorticoid effects and only anti-inflammatory glucocorticoid effects. And the last two, betamethasone and dexamethasone, those are long-acting, so 36 to 72 hours. So those work pretty well for chronic therapy. They last for a long time, and if you only want anti-inflammatory activity and you're not supplementing native hormone, then those drugs are good choices. So those are some just generalities about these medications and how we classify them. So you want to keep in mind its mechanism of action, how long it acts, and its ability to be given then in different formulations. So some of these drugs work better when injected, and some of them work better when oral. There are so many different applications of drugs in this class. So they can either be drugs that increase activity and work in an agonist fashion as one of these substances, or they can inhibit or block function of these substances. So glucocorticoids, remember, one of the main reasons we use them is that they're anti-inflammatory. So we can use them in a whole host of inflammatory conditions, including chronic inflammatory conditions like Crohn's disease or autoimmune diseases, different allergies, asthma, skin conditions, adrenal insufficiency, immunosuppression and organ transplant, and even at high doses, we can use them in cancer therapeutics, sometimes to offset the effects of other medications. We might want to block glucocorticoid production in cases of hypercortisolism, like Cushing's syndrome. There's newer evidence that shows it's useful in mood disorders like depression and anxiety. Side effects from glucocorticoids. So these medications have a wide array of side effects. We might want to block their activity to give some relief. And there's some preliminary data that specific autoimmune disorders might benefit from blocking cortisol production. Mineralocorticoid agonists might be given for replacement in adrenal insufficiency, congenital adrenal hyperplasia, orthostatic hypertension, congestive heart failure, low levels of potassium, that hypokalemia, whereas antagonists, that's your typical like aldosterone blocking effect you would get from something like a diuretic. So hypertension, congestive heart failure, and different edematous states like ascites, primary hyperaldosteronism, and we'll talk a little bit about polycystic ovarian syndrome. So there's one, spironolactone, that seems to be really useful for PCOS. With androgens in insufficiency states, we want to give an agonist, different age-related conditions associated with cognition, mood disorders, and sexual dysfunction, specifically with libido. Antagonists would be mostly androgen-dependent cancers, hyperandrogenism, that's more preliminary in nature in that data, and then autoimmune diseases like lupus. So we're talking mainly about, again, increasing activity or replacing a hormone or blocking activity. Just to give you some insight into what we see natively in the body with the pharmacokinetics of glucocorticoids, with our endogenous hormone being cortisol. So if you take a look at this diurnal curve here, it's starting at midnight, and we see that levels of cortisol are relatively low throughout the night, and then upon waking they start to rise, and they're relatively early in the early to midday, and then they start to go down again as the day progresses. And this is what we would want to see if we were sampling throughout a 24-hour period, this nice diurnal curve. We will see that this curve does shift in different ways in cases of acute and chronic stress where levels just become really, really high and they don't really get suppressed during sleep. And in burnout, actually levels of cortisol get really low, which might help explain the burnout syndrome, where there's just a lot of lack of motivation, cynicism, and really the body is not responding anymore to stress. And the kinetics, this is about 10 to 20 milligrams daily that is released in a circadian style associated with ACTH pulses from the pituitary. The half-life of cortisol is about 60 to 90 minutes. About 75% binds to its specific trafficking protein, and the half-life can go up whenever there's cases of stress, hypothyroidism, liver disease, or giving large doses of hydrocortisone, which will mess with the HPA axis. So going through those medications that were on the table that I showed you before, let's talk about drugs that are used as glucocorticoid and mineralocorticoid agonists first. We'll start with hydrocortisone. And remember, hydrocortisone is the closest to cortisone, which is the precursor to cortisol in our body natively. This is a short-acting compound, and the way that it works is it binds to both glucocorticoid and mineralocorticoid receptors. This, besides our cortisone, is the only medication with that one-to-one activity. So not only can we use this medication for typical allergic reactions or inflammatory conditions, when you're supplementing a hormone in the case of a deficiency, you're getting both GC and MC activity with it. So primarily this is an oral medication or a topical prep that can be given also rectally. There are also different injectables available. And here's your rule. When you are giving anything, but specifically a glucocorticoid, because they do act on every cell in the body, you're going to have a lot of side effects. So if you give a drug locally, meaning just on the area where you have the lesion or the appearance of whatever it is associated with the disease, so the lesion could be a rash, for example. If you give something locally, you're limiting the amount of transfer that drug has throughout the body, so you have less side effects. However, if you give something systemically, like by injection, it's going to hit every cell in the body, and it's going to give you a greater array of side effects. So you have to keep that in mind. And if you can choose local, that's always best. So if somebody has a rash, a hydrocortisone cream is a nice way to locally treat that rash rather than giving them a pill to swallow. So you want to think about that, how long you're going to give it and what you're treating and what the side effects will be. So we've got our oral, and then topical rectal, and then our injectables. So there's an IV soluble salt of hydrocortisone that's available for emergency situations like deficiencies or allergic reactions or inflammatory flares. There is a hydrocortisone acetate injectable available for intra-articular, that means within the joint space. That's another way to locally treat something. If somebody has a flare of arthritis or joint pain in their knee, for example, you can inject the medication directly into the joint capsule to allow local treatment. There's also an IM preparation, hydrocortisone sodium succinate. That's a systemic treatment. It only lasts for about 1 to 2 hours, so you have to give it every 6 hours. And then there is a secondary IM preparation, prednisolone acetate, and that's an alternative to your hydrocortisone IM. So this is your one-to-one glucocorticoid, mineralocorticoid medication, can be given locally or systemically, and it's short-acting in nature. All right, now we have our one mineralocorticoid agonist, our Fludrocortisone. So that's the one that starts with F. It's a little bit different in that it does not bind to to glucocorticoid receptors. It only binds to mineralocorticoid receptors. Those mineralocorticoid receptors, again, they are inside of the cell, and they would bind to their receptor there, translocate into the nucleus to give us transcription, translation, new proteins. And in this case, we're affecting mainly this pump that's associated with aldosterone activity. And if we think about what aldosterone naturally does in the body, it is our sodium sparing hormone, meaning that instead of a pump pumping sodium out to go into the urine so that we lose it, we would turn off essentially this pump or alter activity of that pump so that we keep our sodium. But in exchange for that, we're going to exchange out our potassium. And then something that goes with that is also hydrogen ion, which is our main acid in the body. So that helps explain to you your mechanism of action and also predict the side effects. We're looking at a sodium-potassium pump and then the movement of hydrogen. If we're giving a mineralocorticoid, we're blocking that activity and then keeping the sodium, but then losing potassium and hydrogen in the process. All right, so this is a systemic type medication, so it's used mainly for replacement therapy in adrenal insufficiency. An example of that would be Addison's disease. It is not supposed to be used any other time when there is no mineralocorticoid deficiency. You would have really high blood pressure from retaining all of that sodium. It's an oral medication. It's metabolized in the liver, and the side effects are what we would predict physiologically through aldosterone activity. Aldosterone raises the blood pressure through that sodium-potassium pump activity, so the side effects then are pretty predictable. Hypertension, fluid retention, and edema, increased work of the heart, and then cardiac hypertrophy, leading to possible congestive heart failure. Because we're losing potassium, we can see hypokalemia, and because we're losing acid, we can see hypokalemic, so low potassium, alkalosis, which is the development of a high pH, which makes sense because we're messing with our hydrogen ion, which is our acid. So fludrocortisone, intermediate acting mineralocorticoid. All right, moving along, we're back to our glucocorticoid medications with some minimal mineralocorticoid effects. Prednisolone and methylprednisolone are two intermediate acting medications with some minor mineralocorticoid receptor binding. So they don't have zero sodium retaining effects. They do have some. The way that these drugs work is binding, again, to both glucocorticoid and mineralocorticoid receptors. They are used for systemic conditions. So prednisolone is the primary pharmacotherapy for anti-inflammatory conditions, and methylprednisolone is used in large doses as a pulse therapy. And what I mean by that is you can pulse high doses of something. If we're looking at the treatment that's long-standing of something, we can give high pulses of a dose to minimize chronic long dosing at high levels by pulsing these higher doses in between. So here would be an example protocol. Somebody's admitted and they're immediately given this really large dose of methylprednisolone. And they're given that for a few days, and then they're switched to an oral prednisolone, which is our other medication, in a much lower dose, 30 mg. And they're on that for 4 days. And then they're pulsed again with this high methylprednisolone dose, and then so on and so forth. And then they'll eventually be tapered down. So when you think of prednisolone, that's your oral medication. There's also an IM and then an eye drop variety available. That's your anti-inflammatory drug. And then your methylprednisolone is mainly IV. It can also be oral, but that's your pulse. So this is going to be the high dose for pulse, and this is going to be the drug used for more short-term chronic, if that makes sense, therapy of inflammatory condition. The metabolism of this is pretty straightforward. You get the formation of inactive metabolites, so that means they're going to leave the body relatively quickly as substances. They only last for that intermediate period of time. If you want to increase the amount of drug that's available to work biologically, which we refer to as the bioavailability of a drug, you can give a prodrug. What that means is that you're giving a substance that when it gets to the liver and is modified, it turns into the active drug. So prednisone is a prodrug for what we just spoke about, prednisolone. So when you give prednisolone, your body is immediately converting it into waste products. When you give prednisone, your body converts it immediately into prednisolone, which is an active substance. So that means there's higher amounts of drugs available to work biologically. So prednisone is a nice way to get more drug into the system, and it's used in a lot of chronic inflammatory conditions, in allergic reactions, asthma, COPD, different hypersensitivities, organ transplant, and also for adrenal insufficiencies in the case you need replacement. Prednisone is mainly oral, and you may have seen these taper packs with prednisone. So that's what a taper pack would look like. You're giving somebody a big loading dose at the start, and then they're tapering gradually throughout their treatment. And this is what you would see as the patient handout. So they've got those 6 pills to take that first day. So they're going to have to take 2 before breakfast, 1 after lunch, 1 after supper, and 2 at bedtime. The next day, they're only going to take 5, and then 4, 3, 2, 1. And then they should be done with it. So what makes prednisone different is that its metabolism is converting it into an active metabolite, which is our active compound, prednisolone. So this is a nice oral preparation. It gets more active drug into the system than prednisolone, which is just broken down into nothing. All right, the next few we're going to talk about have 0 mineralocorticoid activity. There's 3 drugs with 0 mineralocorticoid activity, which means if you just solely want anti-inflammatory properties, these are your number 1 bets to not get any sodium retention. That's why you will see, like sodium retention with prednisone. You get that kind of moon face. People can get edema from it. With these 3 meds we'll talk about, you're not going to see that because it doesn't bind to those receptors. It's a glucocorticoid agonist only. And triamcinolone is mainly a local treatment for things, although it can be given systemically as an injection as well. But it is preferred as a local treatment because of its side effects. It's given locally for allergies, dermatitis, things like rhinitis, conjunctivitis, contact dermatitis, eczema, psoriasis, joint pain, eye conditions, oral ulcers. So anything where you can get a target for local inflammation, you can use this med. So you can see that there's a nasal spray available for rhinitis. This is the dental paste preparation. So if patients have a canker sore or cold sore inside of their mouth and they want relief from that, they can use this preparation for it. It does undergo some extensive hepatic metabolism, and why I mention that you want to be conservative with it as a more chronic therapy is because the muscle wasting from chronic use can be very severe. Anorexia, so the lack of motivation to eat, and depression occur with high doses at chronic levels, so it is best kept in mind for a local treatment used locally when possible. That injectable, then, we would want to use that as an IA injection, not necessarily a systemic injection. Again, we have a medication with 0 mineralocorticoid effects, and it's dexamethasone. Dexamethasone is also long-acting, so it's useful for treating chronic conditions. It was used during COVID to help with some of the inflammation in the lungs and everywhere else that we saw inflammation from COVID. The indications are anywhere you want really potent anti-inflammatory effects. So different autoimmune conditions, allergic conditions. It's helpful in respiratory conditions like COVID. It can help alleviate symptoms associated with chemotherapy. It's also useful for cerebral edema, and the reason for that is it actually crosses the blood-brain barrier. And in order for something to work in the brain, it's got to get to the brain. So that makes dexamethasone a good choice for treating something in the brain. Glucocorticoid replacement in cases of adrenal insufficiency. And you might know that this is used in the case of suppression testing. So if you give a huge dose of dexamethasone, you can suppress the HPA axis if that's your treatment goal for a hypersecretory state. You can also do a dexamethasone suppression test to see if Cushing's syndrome is located in the pituitary or if it is the result of a corticotropin releasing tumor elsewhere in the body. It can be given orally, IV, IM, and topically. And when it's metabolized into inactive metabolites. All right. Finally, we've got betamethasone. This is another one with no mineralocorticoid effects. It is a long-acting preparation, and it's mainly used as an anti-inflammatory. So same things we just saw with dexamethasone. We see autoimmune and inflammatory conditions, severe allergic reactions, acute exacerbations of respiratory issues, dermatologic conditions it's really helpful for. It reduces the amount of inflammation and specifically the itching, which is associated with allergies. So that is really helpful. It has I always say, if there's something special about a drug, you should remember it. Something special about this is if there's a case of premature labor, betamethasone can be administered in the case that we would want to hasten maturation of the fetal lung. So betamethasone is used in that special condition for premature labor and maturation of fetal lung development. It can also be used like dexamethasone in adrenal suppression in hypersecretory states because of HPA suppression. It can be given orally, IV, IM, and topically. It also crosses the blood-brain barrier and the placenta, which makes it a good choice for its use with preterm infants if it can cross the placenta rather easily. Most drugs can, but we have to mention that here. So here you've got some different preparations. You've got a cream of betamethasone. You've got its cream that is combined with a antifungal, which is going to come into play later. So anything that ends in azole is an antifungal. So that means this can be used for different like fungal infections. But remember that antifungal for later. There's a foam preparation of it, and then there's an injectable preparation. So lots of different ways. And remember, if you can give something locally, give it locally. Definitely you want to give it systemically for emergencies and for fetal lung maturation. All right. Spoiler alert. Not much of a spoiler because I've mentioned it a bunch of times. Because glucocorticoids act on every cell in the body, there's a ton of side effects from it. And you're either going to get those side effects from prolonged therapy at supraphysiologic doses. Supra means above, so greater than what we would make physiologically, or withdrawal from those substances. It is such a long list of side effects from chronic use. I like to think of just mainly its activity with carbohydrate metabolism, so seeing abnormalities with lipid regulation and lipid deposition, and then also muscle wasting and tissue thinning and immunosuppression as these big ones. But there's so many others. You can see this table here of chronic side effects and everything that can be associated with their chronic use. There's some great mnemonics that you can find online, like this is Cushingoid Map, to help you remember cataracts, ulcers, striae, hypertension, infection risk, necrosis, growth restriction, osteoporosis, increased intracranial pressure, diabetes, myopathy, adipose tissue hypertrophy, pancreatitis. So whatever it takes, but if you know the physiologic effects of glucocorticoids and that, you can predict what these side effects are going to be. So the longer people are on these and the higher dose that they're on for an amount of time is going to increase their chances of side effects. Giving drugs locally does decrease a lot of these effects. All right, in addition to chronic use at supraphysiologic doses, we mentioned that withdrawal is the other reason you might get side effects. The most common thing to see from withdrawal, is just flare-up of the underlying disease. So if they were taking a steroid for a dermatologic condition and they stop taking it, there is a huge dermatologic flare that's associated with that. The second most common is adrenal insufficiency if you remove the person from the drug too rapidly. With regards to that suppression, some people take weeks to recover, some take months, some take a full year. So there's lots of withdrawal protocols that are available, and they should involve gradual daily dose reduction or moving to an alternate day dosing schedule before eventually moving to a gradual taper in dose to try to mitigate some of these withdrawal effects. However, if you see that the withdrawal syndrome is present, so you'll see like a fever and joint pain and muscle pain, that's usually the first sign. So once you see that pop up, returning to the high dose, that's warranted in that case. And just to give you an idea of how intertwined these things all are, this table shows you, I'm going to make it bigger for you there. So here are all of the different systems, and then these letters here let you know if it is Cushing's syndrome, glucocorticoid withdrawal syndrome, or adrenal insufficiency. So with the brain, we'd see mood and cognitive disturbances and insomnia from, Cushing's syndrome and withdrawal, insomnia just from Cushing's. Being excessively sleepy, you only see it in withdrawal. So we can go through withdrawal. So we'd see anorexia, weight loss, physical deconditioning, muscle fatigue, discomfort, those myalgias I mentioned, adrenal insufficiency, low blood pressure, hypoglycemia, anorexia, vomiting, weight loss, and then that myalgia, fatigue. So being able to distinguish between insufficiency and withdrawal syndrome is important. But remember, if the withdrawal syndrome comes about or you see adrenal insufficiency happen, moving to the higher dose and then trying the taper again is warranted in that case. All right, to finish up for you, so those were all agonist things where we're replacing hormones. What if we want to inhibit those things because somebody has Cushing's syndrome or disease or some other hypercortisolemia that exists? Well, we can use inhibitors of synthesis. Here is a nice biochemistry graph with the pharmacology plugged in for you with this cholesterol manufacturing pathway. So when cholesterol enters the body, it is converted into pregnenolone, and then pregnenolone really becomes all other hormones by a variety of enzymatic alterations. We can inhibit then at various steps the production of these steroid hormones. Some of them have nothing to do with hormones in general and might surprise you to see them there. Remember how I said if it ends in azole, it's an antifungal? Well, ketoconazole is an antifungal. Why is it in here? Well, I'm going to tell you about that. So inhibitors are used to treat any kind of hypercortisolism like Cushing's or adrenal carcinoma. Remember, for these things, because they're almost always caused by some sort of adenoma or a growth, surgery is the first line therapy. Surgery isn't always fully effective, and not everybody is a candidate for surgery. So drugs become really useful as an effective agent or an adjuvant or additive agent in treatment. Medications that block ACTH, which would drive cortisol release, and steroidogenesis itself are useful. With regards to things that can block ACTH, for those of you who have me in real life, we mentioned these medications in the pituitary chapter. Paceriotide and cabergoline are two medications that we use for other things. So paceriotide is a somatostatin analog that not only inhibits growth hormone and is used in the treatment of acromegaly, it also inhibits ACTH, so that will limit the HPA axis activity. Cabergoline is a dopamine type 2 agonist, which we use for a whole type of prolactin things, and then that's that for right now, but pituitary things. Most corticotrophic tumors are positive for the dopamine type 2 receptor. So we can alter ACTH activity by giving cabergoline. So those are two medications that are somatostatin and dopamine type 2 specific, but they also block ACTH activity. All right, now we have the steroidogenic inhibitors themselves. Remember, genic comes from genesis, which means creation. So these medications are going to block the creation of adrenocorticotropic hormones. There is one that's FDA approved. Osilodrastate is an oral med that's approved for adults with Cushing's who aren't surgical candidates, and it seems to be very useful. Metirapone and immunoglutathione are off-label drugs that are used for inhibition of steroidogenesis in cases of hypercortisolemia. These three drugs all work in the same basic way, some of them at multiple steps downstream as well, but in the most basic form, all three are instrumental in the blocking of the initial conversion of cholesterol to pregnenolone. 11-beta hydroxylase is the enzyme that is heavily contributing to this alteration. So if you block activity of this enzyme, you're going to block all steroidogenesis. So all three of those drugs are working in that same type of mechanism. Only one is FDA approved. Metirapone immunoglutathione is off-label, but still shows efficaciousness for blocking steroidogenesis. All right, and then we have steroidogenesis inhibitors of other classes. So these things have no relation really to the steroid class. They just, turn out to affect parts of steroid production. The first one is relatively well known, ketoconazole. Again, it ends in azole, which means it's an antifungal. Believe it or not, we have more in common than fungi than we do with fish. One of those being that we have a membrane that's made out of fats. We have cholesterol, and fungi have ergosterol. And what that means is when antifungal medications are targeting like a mycoses, if this is a fungi, he's a fun guy. Look how happy he is because he's fun. The way that these drugs work is they prevent ergosterol synthesis. Now he's not a fun guy anymore. He's dead. He's dead. That's what these drugs do, is that they block the creation of that membrane of fungi. Because ergosterol is related to cholesterol, which is what we make steroid hormones out of, turns out there's a little bit of crossover there. So not only is it useful in breaking down ergosterol synthesis, it's also useful in blocking cholesterol synthesis, which we need to make hormones with. So ketoconazole can be useful in Cushing's disease. You would give an oral dose that's higher than the dose you would use for antifungal medication. And if somebody has, like, in this case, they might be taking it PO for like toenail fungus, for example. So the dose would be much higher. And what everyone should keep in mind about antifungals in general is that they are hard on the liver, which is why we give them topically when we can. When we give them orally, we test people's liver enzymes quite regularly, and we test them before we start the drug because it does mess with the liver. These medications also use so many enzymes that we need to break down other drugs, which means you're going to create a lot of interactions with ketoconazole. The side effects are hepatic dysfunction then, and severe hepatic injury. So you make sure you check the liver, check it before, check it during, check it often. Some other things that are useful, etomidate, you might have seen on that treatment like flow chart for Cushing's disorder. Etomidate's actually an anesthetic. So that means when you give it, it's a hypnotic. You can put people under in twilight sleep. If you give it IV at subhypnotic doses, then it prevents steroidogenesis to some degree. You give it in a big bolus dose, which is then followed by a continuous infusion, which you give until symptoms start to get better. And this is really indicated in an emergency setting. And this is the treatment of choice for the Cushing crisis, where cortisol levels go really, really high. Another thing that's really like out of left field is midotane, and that's actually a drug used in the treatment of cancer. So this is used for inoperable carcinomas, so not adenomas, which are benign growths, but carcinomas are malignant growths. So if somebody has a malignant growth that is causing steroidogenesis, that's interacting with the body in a maladaptive way, you can give midotane as a chemotherapeutic. It's a cytotoxic agent, so it kills individual cells. You give it orally, and the dose is pretty high, and the maximal dose that can be tolerated is really what you can maintain people on, because you want to kill as many of the cells as possible. Chemotherapeutics and other cytotoxic agents aren't like gentle drugs. They do have a lot of side effects associated with them. They do really attack the adrenal, so insufficiency is expected, GI disturbances, and ataxia as well. Finally, with other classes, we have spironolactone, which is actually a diuretic, and it's called the potassium-sparing diuretic because it works on that pump we were talking about before that exchanges sodium for potassium. And when aldosterone turns off that pump, we retain sodium but then lose potassium. So it's called a potassium-sparing diuretic because the main side effect of other diuretics is that you have low potassium. So if you start them on furosemide, which is Lasix, and you see hypokalemia, you can move them to spironolactone so that they don't lose their potassium. Turns out, not only does that area in the body that is responsible for mineralocorticoid activity, it's also responsible for for its anti-androgenic properties. Spironolactone is given to treat acne at a higher dose than it would be for diuretics. It's also really useful in not just the acne associated with polycystic ovarian syndrome, but also the entire syndrome, the obesity and the hirsutism, or the hair growth that exists there, because PCOS in and of itself is a disease of excessive androgen. So spironolactone really is useful for those conditions. It's taken orally, and because it's potassium sparing, you keep your potassium, meaning a side effect might be hyperkalemia, or high potassium in the bloodstream. Last thing, I just want to mention adrenal androgens. So we talked about spironolactone being really good at blocking androgen activity. If we give an adrenal androgen agonist, we can alter some activity. So I just want to be straightforward with the science, where it is typically said that there's not a ton of puberty or muscle building benefits associated with DHEA or androstenedione, which is the precursor to it. It's really important with axillary and pubic hair growth during puberty, but because DHEA declines through adulthood, it is sold as a supplement. However, when you do start to look into the literature, you can find some really useful things. For example, there's some sports medicine studies that measured athletic recovery and then correlated that also with muscle mass and taking of DHEA. And the way they determined muscle mass was measuring thigh circumference. So we found that their recovery and their performance went up, and so did the size of their thigh muscles. So take that for what it is. It also is used in women with lupus. And this is a study, it's from 2002, but I think it's a nice graph. It's showing you here the percentage of participants without a disease flare. So these are women with lupus, and those on placebo. After about 200 days, the amount of those without a flare on placebo was between 60 and 70%, but those supplemented with DHEA, about 80% of them did not have a disease flare. So it does seem to have some utility in lupus. It also is part of a conversation about libido and the maintenance of libido in males and females. But we will talk about that in another lecture. Like and subscribe. All right, for those of you who like questions, you can stop the video here, see if you can answer it. And if there is anything you want to know, feel free to drop me a line. There's plenty of things on here that might be useful for you. And I hope you learned something today. And thank you, everybody. Stay smart.